All right, next up, our last presentation for the day is by Jacqui Richmond and Jane Dicker from Australia. Who are, sorry, I will say the title. They're presenting on continuing the discussion about peer-nurse partnerships in hepatitis C elimination efforts.
Thank you, Sophia, and thank you to the organising committee for the opportunity to report back on a workshop that we conducted at last year's INSU. On behalf of on behalf of our co-authors who represent nurses and peers from across the world. So Jane and I would first like to begin by acknowledging that we both work and live on the lands of the Wurundjeri and the Boiwurrung people of the Kulin Nation, and we pay our respects to elders past and present, and that our co-authors from Australia also live and work on other lands that have never been ceded. We'd also like to acknowledge people with lived and living experience. Certainly Jane has mentored me and taught me a lot over the years, and I'm personally very grateful for that investment in me. This is our group. So we ran a workshop last year looking at the peer nurse partnership. We wanted to workshop what is it, what are the barriers, what's going on with it. And so we had 35 participants who attended our workshop. They were predominantly from Australia, England, the UK, and Canada. And we went through a range of workshop activities. So we had two presenters. So Jane and our colleague Sally Watkinson presented on their nurse peer partnership, and Julian and James from the UK presented on their NHS collaboration. We then had a range of workshop discussions about building trust between the peer and the nurse and exploring scope of practice issues. We then, that interagency collaboration that's often happening where you have peers and nurses coming from different organisations, and how does that work in practice? And then data collection. So how do we collect the data, and what data is being collected? So we had three themes that really came out. So the role of the health system in terms of peers and nurses working together, the critical element of developing that peer-nurse partnership, and measuring the impact. Over to you, Jane.
Thank you. Thanks. So, yeah, it was a great workshop. There were so many really good discussions, but it highlighted the importance of building the trust between the peers and the nurses, and there were so many barriers that came out, and it was quite evident Australia had the worst barriers. But, you know, it really showed the system there doesn't respect the therapeutic relationship between us, and that caused so many barriers, like peers couldn't access certain databases and things like that. It hindered it because the peers can do so many amazing things, and then the nurses also wanted to do things that the peers did, and I don't know, yeah. So there was just things like I couldn't look up people's health records because I'm not a nurse, but if I could have had access to that, it would have been a lot better. How do I? Green button. That one there. Okay. So, do you want to do this one, Jacqui?
Sure.
Sorry.
No, you're right. So we talked, there was a lot of discussion about the importance of co-designing these models of care. So it wasn't just, oh, let's get a nurse and let's just add a peer on board, or vice versa, but I think it's probably more the nurse and then the peer being added on. So we really wanted to make sure that there was an equal voice between nurses and peers, and that there was a discussion beforehand about what that actually looked like in practice. And this came through in multiple groups that were discussing this, that there was a real focus on key performance indicators, number of people tested, number of people treated, but that didn't necessarily reflect the depth or the breadth or the achievement of these peer nurse partnerships. So really challenging, and this was particularly present in the UK, where they were very driven by these KPIs. So just thinking beyond that and opportunities to collect other information.
Yeah, so from it came that there needs to be appropriate training for peers and nurses, and the tasks that different roles were given, I think it needs to be not so strict, you know, like there's peers that can do phlebotomy and take bloods and all those sorts of things. There's also nurses that are really good at talking to the people that are accessing the program and not leaving that just for the peers to do it all themselves, you know. But while there do need to be clear boundaries, you know, peers need proper supervision, just like nurses do, but peers didn't seem to be getting it. There needs to be a lot more support for that role rather than dividing it, I guess. It just, yeah.
Yeah, I think it came down to task delineation, not role delineation, because as Jane said, nurses and peers all bring their own mix of skills and expertise and things that they want to include in their scope of practice. So really there was this real challenge amongst the group, like let's not say that's a nursing role and that's a peer role, but let's say, is that something? And this comes down to the co-design element of it as well. In terms of data collection, this was, once again, it came up in multiple group discussions that the data collection needed to reflect the task versus the role, so that, you know, it was very clear that they wanted all of the work to be acknowledged, not just testing and treatment outcomes. There was also a discussion about how the peers and the nurses were aware of double counting that was going on of outcomes. So they were counting it, the nurses were counting it, and the peers were counting it, and there was a lack of communication there. So a very strong desire to be trained, to help inform data collection systems and what data is actually being collected, that nurses and peers feel could really reflect the work that they're doing more appropriately. And once again, being a bit more creative, not just focusing on those KPIs. So we challenged the healthcare system really to recognise the role of peers in hepatitis C elimination activities and to adapt to accommodate to the peer role. So allowing peer access to client data, because that can help inform the approach to care and also engagement, and offer training opportunities to allow for scope of practice expansion. And the issue of data collection and really going beyond testing and treatment to incorporate other aspects of care. Thank you.
Lovely, thank you so much. We have about 1 minute before lunch. Are there any other questions? Mark has a question.
Sorry to keep everyone from lunch. Shut up, man. Mark Stuve, Burnett Institute. This came up in Samara Griffin's systematic review, and we started with the question, what's the impact of nurse and peer-led models of care? And we actually had to change the semantic because none were actually where you could genuinely say they were peer-led. So we turned it from nurse-led, peer-partnered sort of... there are regulatory things in place that, for very good reasons, that limit the ability to task shift, particularly in high-income countries. Probably a question for Jacqui. You've been on lots of advisory committees to change things. How far can we actually take it? How much can we how far do we think we can take task shifting in a high-income country regulatory environment?
Yeah, I think that's a really interesting question, Mark, because, you know, not all nurses and not all peers are made equal, are they? So people bring their own, you know, skill set and what they want in terms of their scope of practice. I think we're seeing evidence of it as well already. I look to peer-based harm reduction in Western Australia, and I see those peers are really empowered. They are, through the lens of care navigation, are actually doing a lot of work that is, you know, it's very, very person-centred. Perhaps they're obviously not prescribing the medication, but up until that point, a lot of that work is being done by peers. I mean, in the last 2-3 weeks, we have nurse prescribing that's just been introduced into Australia. So, God, they will never let me prescribe anything, which is a good thing. But you know, some of my colleagues can do extra training now and prescribe, you know, basic medication. We need to wait to see whether the sky falls in as a result of that. But, you know, there are changes afoot in terms of enhancing and expanding nursing scope of practice. So I do think, not next week, next year, but, I think these discussions are beginning to be had.